Hi, my name is Pamela. I am presenting CHF case. A 69 years old Caucasian female with a history of MI presenting to ER complaining of a racing heartbeat. She states that she has been experiencing increasing shortness of breath for the past 2 months and noticed ankle and feet swelling during the 3 weeks. She described she feels very weak and tired most of the time. She has orthopnea at night. She has an anterior wall MI 5 years ago and had 2 vessel cabbage the following next year for the occlusion of LAD and the circumference. Her other past medical history, including hypercholesterolemia, osteoarthritis, and gout. She was an ex-smoker for 30 years, quit smoking after her first MI. She is allergic to nuts, shellfish, strawberries, and hydralazine, currently on celecoxib and allopurinol, atorvastatin, and aspirin and Plavix. Her father died with heart attack and the mother had several CVA. Her blood pressure is 125/80. Heart rate is tachycardia. She is also tachypnea, slightly warm. There's no problem on her hearing, vision, throat, rail sounds on both lungs, and the resonant sound throughout the percussion. There is extra hard sound on her heart, and the jugular vein distended. There's no GI-GU problem. Skin is normal. Her CBC are pretty normal. She is hypernatremia and hypokalemia. BUN and creatinine also elevated. TSH and T4 are normal. ABG shows low oxygenation. Chest X-ray shows pulmonary edema. Echo shows that she has a significant low ejection fraction. ECG shows consistent with a left ventricular hypertrophy. So here are the problems. Now we are going to discuss the pathophysiology of congestive heart failure and how it influences the clinical abnormal value. This is just a Flemington heart failure diagnostic criteria. The major thing is, I want to show you on the major symptom is JVD, rails, and acute pulmonary edema, and S3 go up. This is congestive heart failure chart. Heart failure is defined unable to pump out the venous blood return, unable to maintain adequate circulation of blood in the tissue. When patient's heart is not pumping out adequate circulation in the tissue, the symptomatic nervous system activates. The heart rate is elevated. The patient explained that she has experienced racing heartbeat. That's one of the increased sympathetic nerve system. Her body was trying to conserve the blood volume to circulate. By initiating the central nerve system, it also vasoconstricts the blood vessel. At the same time, her kidney sense the low fluid volume. It limited renal angiotensin aldosterone system. Now let's look at the RAS symptom. Renal is secreting from the kidney cell, and it senses the change in renal perfusion. Renal is a protease enzyme act upon angiotensinogen, undergoes proteolytic process to form angiotensin 1, converted angiotensin 1 to angiotensin 2. And angiotensin 2 is a potent vasoconstriction. At the same time, angiotensin 2 working on adrenal gland to release aldosterone. The aldosterone is a steroid hormone. It acts on the renal tubule to reabsorb sodium and water. Water always goes with sodium. This is explained why the patient's sodium is elevated and why her legs is also elevated, swelling. So from this diagram, you can see this person has a clear symptom of swelling leg, pleural effusion, pulmonary edema, tiredness, and shortness of breath. So that's why the chest x-ray shows that patient has pulmonary edema from water and sodium congestion. So how does S3 hurts? The S3 heart sound is caused by mitral valve opens. The sudden deceleration of blood flow into the non-compliant of left ventricle. And it sounds like Kentucky, Kentucky, Kentucky. Congestive heart failure is often consequences of the atherosclerotic heart disease. A lot of disease are associated building up the plaque in the vessels. Hypertension, overweight, diabetic, hyperlipidemia, and smoking. This patient already had the history of MI and the pre-existing hypercholesterolemia. She is definitely a high risk for developing congested heart failure. Thank you for watching.